Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, this is Lindsay Smith-Rogers. Today, what do the terms diversity, equity, and inclusion really mean? Dr. Lisa Cooper is a Bloomberg Distinguished Professor at Johns Hopkins and a winner of a MacArthur Genius Grant for her work to understand and reduce health disparities. She speaks with Dr. Josh Sharfstein about recent directives about DEI and her hope for a more meaningful national conversation about pervasive and significant gaps in health. Let's listen.
Dr. Lisa Cooper, it is great to see you and to have you back on Public Health on Call. How are you doing today?
Fine. Thanks for having me.
I think you've been on the podcast a few times over the years, and I remember once to talk about your book, which is called Why Are Health Disparities Everyone's Problem? Do you remember that podcast?
I sure do. It's hard to believe that it's been almost 4 years.
Well, it has been, believe it or not, and it's a topic that it seems like we're going to need to talk a little bit more about, given some of the developments that we've had these days.
Yes, I couldn't agree more.
So maybe just to refresh our memories, since it's been a while, what was the basic argument that you made in your book?
So the basic argument I made in the book was that that really everyone should care about health disparities because it's a human experience that many of us share, if not everyone. Either we belong to a group that experiences health disparities or we know someone who does. But regardless, we all live with health disparities around us because we know that across the globe, whether it's between countries or within countries, there are certain groups that have much more opportunity to be healthy than others. And we see it in all the public health statistics and the mortality rates and the morbidity rates and all those kinds of things. And it was really apparent in the middle of the COVID-19 pandemic.
Right. So just to give some examples, what kinds of disparities did you write about as particularly important for health?
So I wrote about there are health disparities that are pervasive across like numerous conditions and populations. The area in which I do most of my work is in chronic disease, things like heart disease and diabetes and obesity. But one thing that a lot of health disparities share in common is that they're driven by things that don't have to do with so much to do with what people do, but with like what opportunities they have to be healthy. So there are those things that we call social determinants of health, right? Negative social determinants. So where people live, what opportunities they have to have health care, to have education, what they're exposed to in those environments where they live, and whether or not they can be employed. So there are all these things that actually determine whether people have the opportunity to be healthy. And so no matter whether you're talking about chronic disease like heart disease or diabetes, or whether you're talking about an infectious disease, like COVID-19, a lot of the disparities or differences we see between groups of people in experiencing those conditions is based on their living conditions. And these are things that are determined by our society and our social decisions and our political decisions.
The kinds of groups you're talking about, what are they?
Well, I'm talking about people who have low income. I'm talking about people who belong to marginalized racial and ethnic groups. I'm talking about, for example, there might be people who have disabilities, physical or mental or cognitive disabilities. There are just so many different groups that are affected by this. Children, anyone who doesn't actually have like the most privilege in a society is at risk for experiencing health disparities.
Is one of the concepts here that it's hard to lift up health across the country if you're not understanding why some groups are having trouble getting to better health outcomes?
I think you're right. I mean, I think one thing that oftentimes people get confused about is they think that we're aiming for equality, which is a good thing, to be fair and to give everyone the same thing. But in order to achieve, what we call health equity, which is on the other side of the coin from health disparities, you have to give people what they need. And not everyone starts from the same place or has the same needs. And so, one thing we do a lot of times in the United States and other places around the world is that we say, okay, well, we're just going to give everybody the same thing, and then hopefully everybody will be well. Well, people who were already well are going to get better, and those who were not doing well to begin with may get some improvement, but they are still not going to be at the point where they're, achieving their optimal health.
Could an example of that be if you give everyone, say, an insurance benefit, but people in rural areas have no doctors to go to, then it's not really helping, and you may actually need to couple that with telemedicine or some other initiative for them to get the benefit of that.
Absolutely. That's a perfect example.
Great. All right. That's the first part of our conversation, just to refresh everyone's memory about the work that you do and are nationally known for. The last, let's just say, month or so, there's been a lot of attention paid to what is known as DEI initiatives and different directives within the federal government to pull out certain words off of websites from grant applications. And among those words are equity, inclusion, diversity. How do you take all that in?
Yeah. I have been just baffled actually by how these words are being used, because the whole term, all of the terms that are being used are kind of, to me, not being used in the way that they were intended to be used by the people who began to use them in the first place. And so there's this whole sort of phrase that's been created, this DEI terminology, which is, I guess, supposed to mean something that's negative, but in reality, diversity basically just means having people from different backgrounds and different ways of thinking and different life experiences, and making sure that we sort of appreciate that, which is, I think, a basic value, American value, right? And inclusion is including people, and it's a basic sort of human rights kind of perspective, and just being welcoming. And so being welcoming, valuing, different ways of thinking and different experiences and things like that. And then, of course, equity is the final one, which I think many people have misunderstood. And equity just means like everyone has the opportunity to, be their best selves or attain their best health. And so if you take those words separately and look at what they actually mean, I don't think anybody would say that there's anything negative about that, but somehow the terms have been sort of taken and twisted into meaning different things, or they just may mean different things to different people because people have heard them used in a certain way, and now they're identifying it with a certain type of program or practice, and they don't actually really know what the original intention was.
So from your perspective, when you talk about health equity, how would you respond to someone who says, well, that is advancing certain groups over others? I think that is sort of somewhere in the criticism of DEI, is that concept. How would you respond if someone were to say, well, I think talking about equity is just a secret way of talking about boosting one group at the expense of others?
Right. Yeah, I would say that that's actually not what equity is. Equity is about everyone, is about making sure everyone has opportunity and that no one is left behind or disadvantaged. And I think the reason why we have a need to talk about equity is because there have been historical disadvantages, and certain groups have been at a disadvantage. And this is why we actually have a need to pay attention to it. Because if we didn't have all those historical factors or kind of factors in our systems of society, our policies and things like that, that have systematically disadvantaged certain people, then everything would be fine. And we would just, everyone would have equity and we wouldn't need to be even focused on it, right? But the reason we focus on it is because we're actually rectifying things that were not fair in the past, but not overcorrecting, but basically giving to each person and each group as needed, as they need. So, for example, I think you talked about the insurance thing, giving everyone insurance, but then people in rural areas not having doctors. Well, it's also like saying to people, okay, well, we're going to provide you with a blood pressure monitor. You have hypertension. We're going to give everybody blood pressure monitors. But people who are college educated or who have high income, they might have already bought themselves a blood pressure machine. So giving them one doesn't really help them anymore. They already have it. It's the people who didn't have it that benefit more from that particular thing. But the people who had it are not disadvantaged now because other people have it, right?
Yeah. Well, what does it mean to pull down the programs that are trying to understand and reduce different kinds of gaps in health?
Well, I think what it means is that we're going to go back to some systems where people were at a disadvantage for many generations. And I mean, we just have to look at the facts. It's not my opinion. Black people die at 1.5 times the rates of white people from certain diseases in this country. Same for American Indians. Those are just facts. And if we don't do anything to sort of rectify some of those longstanding inequities, and some of them still exist, we're going to see those gaps widening. And some people might say, well, that doesn't bother me because as long as me and my family are fine, I think that's not my problem. Why should I have to worry about that? Well, it affects you anyway. Even if it doesn't affect you directly, the costs of care go up for everyone, right? We also have more kind of social stress and conflict and people not getting along with each other. All those things have negative effects on our children and on our own well-being. So even if your group or your family or your neighborhood is doing fine, if the community just down the road is struggling, eventually those problems are going to end up coming to you.
Yeah, it's a hard message to break through at this particular moment. Do you have hope that there can be a more responsible conversation about these issues?
Well, I always say that, you can't work in this field if you don't have hope, if you're not an eternal optimist. So yes, I still have hope. I won't say that I haven't been really sort of discouraged and, just worried about the current environment. But I do have faith that if people can actually have conversations, one person to another, about what do these things mean to you? Like, what do these words mean to you? What's negative about it? How would it impact you in a negative way? If we could get to understand one another more, maybe we can get past those surface things like what those words mean that just sort of trigger certain emotions from people. I've really been a strong advocate of relationship-centered approaches, not only in clinical care, but also in all the work we do. And sort of really, it's all about people. Everyone wants the best for themselves, for their family, for their children. And that's what we all want. And the more we can sort of look for that kind of common human element and try to get away from just the surface words, and also not have all our communication via social media platforms where you really cannot get to know people as people.
Even people who may be fired up in opposition to DEI care about issues that relate to disparities, in other words.
That's right. And they may have a family member who's got a disability, and DEI is something that benefits those people. And believe it or not, DEI policies have benefited white women because, for example, they didn't have opportunities to be paid well in working environments. And so we all know somebody who benefits from diversity, equity, and inclusion policies. And especially when it comes to being healthy. I mean, if you can't if you're not healthy, you can't do almost anything else you want to do in your life.
Well, I appreciate your perspective, and I hope that you're right. When the political storm settles a bit, there will be some space for more meaningful conversations.
I certainly hope so.
Dr. Cooper, we'll have you back to talk about it. So thanks so much for catching up with me today.
Thanks, Josh.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Cesiri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Cesiri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.